Diagnosing Asthma and COPD using Spirometry. Hello and welcome to this microlearning module on diagnosing asthma and COPD using spirometry. Before we dive into the specifics, let's understand what spirometry stands for. Spirometry is widely recognized as the gold standard test for diagnosing obstructive airway diseases or OAD, such as asthma and chronic obstructive pulmonary disease, COPD. Integrating spirometry into routine clinical practice is essential to enhance patient care significantly. Adhering to the standardization of spirometry guidelines issued by the American Thoracic Society, ATS, and the European Respiratory Society, ERS, can increase the accuracy and quality of spirometry measurements. This, in turn, ensures better diagnosis and treatment outcomes for patients with asthma and COPD. Let's move ahead and explore the indications of spirometry. Spirometry helps distinguish between asthma and COPD, measures the extent of airflow obstruction to assess disease severity, and is mandatory for diagnosing COPD, Gold 2023. Provides a quick and precise evaluation of airflow obstruction, helps grade the severity of obstruction, identifies restrictive lung conditions, quantitatively evaluates how well patients respond to treatment. A valuable follow-up tool, also used for pre-surgical evaluation. Detects airflow obstruction in at-risk populations, including smokers, ex-smokers, and patients with respiratory symptoms. Spirometry results serve as a powerful motivational tool for patients to quit smoking. Please make sure not to send your patients for spirometry if any of the following contraindications are present: active pulmonary tuberculosis, history of cardiac surgery or heart attack within the past week, recent brain, sinus, middle ear, thoracic, abdominal, or eye surgery, and patient unwilling to perform the test. Equipment required for spirometry. Now that we've understood the indicators and contradictions of spirometry, let's take a look at its requirements. It is essential to have a spirometer of good quality. Calibration verification is highly recommended by ATS or ERS to perform daily calibration verification with a 3 liters calibration syringe at low, medium, and high flow to detect any problems within 1 day. Calibration check ensures that the spirometer is within calibration limits, with a maximum permissible error of plus or minus 3.0% accuracy, linearity, and repeatability, and plus or minus 2.5% error when tested with a 3 liters calibration syringe. Follow the manufacturer's guidelines for routine checks and maintenance, and maintain a log of calibration results, repairs, and any other alterations. Place a thermohygrometer in PFT lab to measure room temperature. Most modern spirometers will have an inbuilt temperature sensor, which is preferable. It is recommended that ambient temperature should be accurately recorded to within 1 degree Celsius, and that spirometric testing should only be done with ambient temperatures between 17 and 40 degrees Celsius. Record the patient's exact age, height, weight, gender, and ethnicity accurately. Most spirometers come with a built-in database of various predicted formulas. It is preferable to use the 90% of the European community for coal and steel values. Use one-time bacterial viral filters and correct mouthpieces to perform spirometry. Keep a waste basket ready for discarding used mouthpieces and filters, and ensure there is a proper system in place for disposing medical waste. This is to be used so that there is no air leak. Provide a chair without wheels for subjects. Ensure that drinking water is available. Offer tissues or paper towels to help patients deal with secretions. Check that there are enough supplies such as hand sanitizer or hand disinfectant gel, disposable gloves. Instructions for the patient. Now, let's take a look at the guidelines that a patient must adhere to before going in for spirometry. No smoking within 1 hour before testing as nicotine causes airway constriction. Avoid alcohol within 8 hours before testing, as the cooperation of patient is reduced. Do not exercise within 1 hour before testing, as vigorous exercises causes airway constriction. Have light meal. Avoid a large meal. Within 2 hours. A heavy meal will reduce the ability to take the deepest breath possible. Do not take medications for asthma and COPD on the day of the test because it causes bronchodilation. But if the patient is on treatment for any other illness, then those medications can be continued. If you are on treatment for BP, IHD, DM, or other illness, please take these medicines. When these conditions are observed, postpone the test by a day or two, but do mention the condition. Withholding of drugs. Now let's go ahead and explore the importance of withholding drugs. If your patient is having asthma or COPD and is on treatment, then he should withhold his drug. These are certain drugs that will do bronchodilation and falsely give you high values. So, we have to withhold such drugs, and these are the timings. ICS can be continued. Short-acting bronchodilator within 6 hours. If the subject has used an inhaled short-acting bronchodilator, such as salbutamol, in the last 4 to 6 hours, then the spirometry readings may not be accurate and show false high values. Moreover, bronchodilator reversibility will be unreliable. The following drugs must be withheld for the below duration before conducting a spirometry test. SABA. Example, albuterol or salbutamol should be 4 to 6 hours. SAMA. Example, ipratropium bromide should be 12 hours. LABA. Example, formoterol or salmeterol should be 24 hours. Ultra-LABA. Example, indicatrol, vilantrol or olodatrol should be 36 hours. LAMA. Example, tiotropium, umeclidinium, aclidinium or glycopyrronium should be 36 to 48 hours. Moving ahead, let's take a look at predicted values. Normal values for FEV1 and FVC are based on population studies and vary according to age, height, sex, race. Therefore, it is important to record the patient's exact age, height, weight, gender, and ethnicity accurately. Most spirometers come with a built-in database of various predicted formulas. It is preferable to use the 90% of the European community for coal and steel values. These predicted values are determined by age, height, gender, ethnicity, or race. Instruct and demonstrate the test. Let's take a look at how the test must be performed. Patient must remain in an upright position, elevated chin, and neck lightly extended. Lips must be sealed on the mouthpiece correctly. Inhale rapidly through your mouth until completely full. Exhale with maximal effort until completely empty. Inhale with maximal effort until completely full. And give 1 or 2 trial runs with the mouthpiece. FEV1 and FVC maneuver. Test procedure. Now that we've understood how to instruct and demonstrate the test, let's explore the 4 distinct phases of the FVC maneuver. Phase 1. Maximal inspiration, which means to inspire as deeply as possible, not just take in a deep breath. Phase 2. A blast of expiration. In this stage, one must ensure maximal expiration to blast, not just blow. Phase 3. Continue complete expiration till a 1-second plateau is achieved, or for more than equal to 15 seconds. This includes using appropriate body language and phrases such as keep going. Phase 4. Inspiration at maximal flow back to maximum lung volume. It involves maximal inspiration after forced expiration. Additionally, it is important to note that for spirometers that measure inspiration and expiration, there are 4 distinct phases of the FVC maneuver. The FVC maneuver includes a 4th phase, inspiration at maximal flow back to maximum lung volume. It is a maximal effort to return to total lung capacity to complete the flow volume loop. Comparison of the FIVC with the FVC will provide feedback to the operator on whether the patient began the forced expiration from full inflation. The inspiration is to be in full inflation before and after the forced expiration be coached with equal vigor so that a valid comparison can be made. Criteria of acceptability of the graphs. Let's now understand the criteria of acceptability of the graphs. This is what a good quality graph looks like. As shown, to ensure spirometry graphs are acceptable, the test should begin with maximal inspiration followed by a rapid and forceful start from point 0, achieving a sharp peak that reflects maximal effort. The flow volume graph should show smooth and continuous exhalation without interruptions, hesitation, coughing, leaks, glottis closure, mouthpiece obstruction, or additional breaths. The inspiratory loop should also be smooth and complete the cycle without irregularities. In the volume time graph, the curve must rise rapidly at the start, indicating strong effort, and should either plateau for at least 1 second at the end of exhalation or have a forced expiratory time, FET, of at least 15 seconds. Meeting these criteria ensures accurate and reliable lung function results. There should be 3 acceptable graphs. Now that we have understood the criteria of acceptability through graphs, let's explore the criteria for acceptability according to ATS or ERS 2019. Back extrapolated volume less than equal to 5% of FVC or 100 ml, whichever is greater. No cough during the first second of expiration. No glottic closure in the first second and after first second of expiration. Must achieve one of these 3 end of forced exhalation indicators. Expiratory plateau in the last 1 second of expiration. Expiratory time greater than equal to 15 seconds. Or FVC is within the repeatability tolerance or is greater than the largest prior observed FVC. No evidence of obstructed mouthpiece, no evidence of leak, and FIVC minus FVC must be less than equal to 100 ml or 5% of FVC, whichever is greater. This graph demonstrates the repeatability criteria in spirometry, best observed in the volume time curve. To ensure accuracy, the difference between the largest and the next largest FEV1 and FVC values from acceptable tests should be within 150 ml of each other. This helps confirm that the results are consistent and reliable. For a valid test, a minimum of 3 acceptable tests must be performed. If the criteria are not met within 3 tests, additional attempts are needed. A maximum of 8 tests can be conducted to achieve repeatability. Points to remember. A poorly performed spirometry increases the risk of misinterpreting results. Ensure that there are 3 acceptable graphs and 2 repeatable readings of FEV1 and FVC for both pre- and post-test. A maximum of 8 blows are allowed. By simply analyzing the shape of the curve, one can determine whether there is an obstruction and, if so, assess its severity effectively. Let's look at the 5 key parameters for quality assurance of spirograms. FVC, forced vital capacity, the maximum volume of air that can be forcefully expired or inspired during the test with maximal effort. FEV1, forced expiratory volume in 1 second. The volume of air forcefully expired in the first second of maximal expiration, indicating how quickly the lungs can be emptied. FEV1 or FVC ratio. FEV1 expressed as a percentage of FVC, providing a clinically useful indicator of airflow obstruction. PEF, peak expiratory flow, measures the maximum speed of expiration, a sensitive indicator of large airway narrowing. FEF 25-75, forced expiratory flow 25 to 75%, measures airflow between 25% and 75% of FVC, serving as the most sensitive indicator of small airway narrowing. Now, let's discuss about the grading criteria for the spirometry report. The FVC and FEV1 should be graded separately. For grade A, there should be greater than equal to 3 acceptable graphs and 2 repeatable readings for FVC and FEV1. For repeatability, the difference between the largest FVC and the second largest FVC of acceptable tests should be within 150 ml of each other. Also, the difference between the largest FEV1 and second largest FEV1 of acceptable tests should be within 150 ml of each other if the patient is greater than 6 years old. For children who are less than equal to 6 years old, the difference between the largest FVC and the second largest FVC of acceptable tests should be within 100 ml of each other. Also, the difference between the largest FEV1 and the second largest FEV1 of acceptable tests should be within 100 ml of each other. For grade B, there should be 2 acceptable graphs and 2 repeatable readings for FVC and FEV1. For repeatability, the difference between the largest FVC and the second largest FVC of the acceptable tests should be within 150 ml of each other. Also, the difference between the largest FEV1 and the second largest FEV1 of acceptable tests should be within 150 ml of each other if the patient is greater than 6 years old. For children who are less than equal to 6 years old, the difference between the largest FVC and the second largest FVC of acceptable tests should be within 100 ml of each other. Also, the difference between the largest FEV1 and second largest FEV1 of acceptable tests should be within 100 ml of each other. For grade C, there should be greater than equal to 2 acceptable graphs and repeatable readings for FVC and FEV1. For repeatability, the difference between the largest FVC and second largest FVC of acceptable tests should be within 200 ml of each other. Also, the difference between the largest FEV1 and second largest FEV1 of acceptable tests should be within 200 ml of each other if the patient is greater than 6 years old. For children who are less than equal to 6 years old, the difference between the largest FVC and second largest FVC of acceptable tests should be within 150 ml of each other. Also, the difference between the largest FEV1 and second largest FEV1 of acceptable tests should be within 150 ml of each other. For grade D, there should be greater than equal to 2 acceptable graphs and repeatable readings for FVC and FEV1. For repeatability, the difference between the largest FVC and second largest FVC of acceptable tests should be within 250 ml of each other. Also, the difference between the largest FEV1 and second largest FEV1 of acceptable tests should be within 250 ml of each other if the patient is greater than 6 years old. For children who are less than equal to 6 years old, the difference between the largest FVC and second largest FVC of acceptable tests should be within 200 ml of each other. Also, the difference between the largest FEV1 and second largest FEV1 of acceptable tests should be within 200 ml of each other. For grade E, there should be greater than equal to 2 acceptable graphs and repeatable readings for FVC and FEV1. For repeatability, the difference between the largest FVC and second largest FVC of acceptable tests should be greater than 250 ml. Also, the difference between the largest FEV1 and second largest FEV1 of acceptable tests should be within greater than 250 ml if the patient is greater than 6 years old. For children who are less than equal to 6 years old, the difference between the largest FVC and second largest FVC of acceptable tests should be within greater than 200 ml. Also, the difference between the largest FEV1 and second largest FEV1 of acceptable tests should be greater than 200 ml. Or, if there is only one acceptable graph, then the graph is accepted, but repeatability criteria is not applicable. The U grade means there are 0 acceptable graphs, but there is greater than equal to 1 usable FEV1 or FVC reading. And for this graph, the repeatability criteria is not applicable. The grade F indicates that there are 0 acceptable graphs and 0 usable readings, and repeatability criteria is not applicable. Exercise: accept or reject. Let's do the quality assurance of the spirometry report. The spirometry report does not contain the volume time graph. In the flow volume graph, there is no visible peak and the signs of glottic closure are present. The grading for both FVC and FEV1 is grade F. Therefore, the spirometry report can be rejected. Let's do the quality assurance of the second spirometry report. In the flow volume or FV graph, signs of glottic closure are present. In the volume time or VT graph, an air leak is observed. The grading for both FVC is grade F and FEV1 is grade F. Therefore, the spirometry report has been rejected. Let's do the quality assurance of the third spirometry report. The flow volume and volume time graph meets the acceptability criteria. The FVC and FEV1 meets the repeatability criteria. The grading for both FVC is grade A and for FEV1 is grade A. Therefore, the spirometry report has been accepted. Interpretation of spirometry. The interpretation of spirometry isn't as hard as it seems. Let's understand it in detail with the help of these graphs. The flow volume loop graph visually represents the degree of airway obstruction, which we can interpret by analyzing the shape and pattern of airflow during expiration. Here's how to interpret it. Dotted line, healthy airways. This represents normal lung function. The peak expiratory flow rate or PEFR and forced vital capacity FVC are within normal limits, and the curve is smooth without concavity, indicating unobstructed airflow. Blue line, mild obstruction. The airflow pattern shows a slight concavity, but PEFR and FVC remain normal. This suggests minimal resistance in the airways. Brown line, moderate obstruction. The concavity increases and PEFR begins to decrease, though FVC is still maintained. This indicates more noticeable airflow limitation. Green line, severe obstruction. The concavity becomes more pronounced. FEV1 is significantly reduced, and FVC also starts to decline. This suggests a severe airflow limitation with restricted lung emptying. Red line, very severe obstruction. The airflow is severely compromised with markedly increased concavity, significant PEFR and FVC reduction, and substantially reduced FEV1. The curve is highly deformed, indicating extreme obstruction. By examining the shape of the curve, especially the degree of concavity and reduction in PEFR, FVC, and FEV1, one can determine both the presence and severity of airway obstruction. The volume time graph in spirometry helps assess airway obstruction by analyzing how quickly a person exhales air over time. The different curves in the graph indicate varying degrees of obstruction. Here's how to interpret them. Black dotted line, predicted healthy airways, represents normal lung function. FEV1, forced expiratory volume in 1 second, and FVC, forced vital capacity, are within normal limits. Blue line, mild obstruction. FEV1 is reduced, but FVC remains normal. The curve still reaches the normal plateau, but at a slightly slower rate. Yellow line, moderate obstruction. FEV1 is further reduced, while FVC is still normal. The curve takes longer to reach the plateau, showing a more significant delay in exhalation. Suggests moderate obstruction with increasing difficulty in exhaling air quickly. Red line, severe obstruction. Both FEV1 and FVC are significantly reduced. This indicates severe airway limitation with marked difficulty in expelling air. By observing the shape of the curve, particularly the rate at which volume increases and plateaus, one can determine both the presence and severity of airway obstruction. Restrictive lung disease is characterized by low FEV1 and FVC, with an FEV1-FVC ratio greater than 80%. Common conditions are interstitial lung disease, pleural fibrosis or thickening, and kyphoscoliosis. Spirometry can only suggest this condition. Confirmation requires measuring total lung capacity. Spirometry interpretation can be done by analyzing the shape of the curves, but a formal diagnosis requires a numerical algorithm. Until now, I have shown you how to interpret based on the shape of the curves and make a diagnosis. But to make a formal diagnosis, an algorithm can be followed based on numbers. Based on this algorithm, you can categorize your patients into 4 groups: normal, restrictive lung disease or RLD, obstructive airways diseases, OAD, mild or moderate, and OAD plus RLD or severe obstruction, just by looking at 2 parameters, that is, FEV1-FVC ratio and FVC percentage predicted. Just with the help of these 2 parameters, you will be able to make the complete interpretation. So, if FEV1-FVC ratio is greater than 70% and FVC percentage predicted is greater than 80%, then the patient can be labeled as normal. But if your FEV1-FVC ratio is greater than 70%, but the FVC percentage predicted is reduced or less than 80%, then it is labeled as restrictive lung disease or RLD. Now, if your FEV1-FVC ratio is less than 70%, then it is termed as reduced ratio obstructive airway diseases or OAD. And going further in the same group, if the FVC percentage predicted is more than 80% predicted, then it is said to be mild or moderate OAD. Again, if the ratio FEV1-FVC is less than 70% and the FVC percentage predicted is reduced, that is, less than 80% predicted, then the patient is labeled as OAD plus RLD or severe obstruction. So, this is how, just by following the algorithm, you can make a confirmed diagnosis. Now, to determine the severity of obstructive airways disease or OAD, the first step is to check if it is reversible. This is done through bronchodilator reversibility testing, where a bronchodilator, salbutamol 200 to 400 mcg, is administered using a PMDI with a spacer or nebulizer. After 15 to 20 minutes, FEV1 and FVC are remeasured. If FEV1 improves by greater than equal to 12% and greater than equal to 200 ml, the OAD is considered reversible and suggestive of asthma. If not, it indicates COPD. Once asthma or COPD is confirmed, the severity is assessed using the FEV1 percentage predicted value. Now, to determine the severity of asthma, we follow the 60-80 rule. If the FEV1% predicted is greater than 80%, the condition is classified as mild asthma. If it falls between 60% and 80%, it is considered moderate asthma. And if it drops below 60%, it is categorized as severe asthma. Similarly, for COPD, the 30-50-80 rule is applied. When the FEV1% predicted is greater than 80%, the severity is classified as mild COPD. If it ranges between 50% and 80%, it is moderate COPD. If the value falls between 30 and 50%, it is considered severe COPD. And when it is less than 30%, the condition is categorized as very severe COPD. By analyzing the shape of the spirometry curves, following a systematic algorithm, confirming the diagnosis using the bronchodilator reversibility test, and assessing the severity based on FEV1 percentage predicted, a complete diagnosis can be made accurately. With this, we've completed the module on diagnosing asthma and COPD using spirometry.